Welcome back to the deep dive. Today, we're taking a journey into, well, one of the body's most vital systems, the pulmonary system.
Absolutely fundamental. Often overlooked until something goes wrong. Right?
Exactly. So our mission today is to really unpack Unit 8 from Understanding Pathophysiology. We'll cover structure, function, and then what happens when things go wrong.
Yeah, both in adults and kids.
We want to give you a clear path to understanding how we breathe, what challenges that, and why it matters. Think of it like a shortcut to the core concepts.
And it's fascinating how this unit builds up, from the tiny cellular stuff right up to the whole system.
You mentioned aha moments before we started.
Definitely. We'll see how even small changes, things you might not think about, can really impact breathing and, well, life itself.
All right, let's dive in. Chapter 28 starts with structure and function. So, the basics, what's the pulmonary system all about?
At its heart, it's gas exchange. Simple concept, complex execution. Getting oxygen in, getting CO2 out.
And the book mentions 3 steps. Ventilation.
Right, ventilation, that's just the mechanics, air moving in and out.
And diffusion.
Diffusion is the actual gas swapping across the lung membranes into the blood.
And perfusion.
Perfusion is the blood flow through the lungs.
Yeah.
So ventilation and diffusion are the lungs' job. Perfusion connects to the cardiovascular system.
Okay, so let's visualize the hardware, the plumbing, as you called it.
Yeah, let's do that. You've got the lungs themselves, 3 lobes on the right, 2 on the left. They sit inside the chest wall, protected by ribs, powered by the diaphragm below.
And the airways.
Air comes in the nose or mouth. That's the upper airway. The nose is actually way better at filtering and warming the air.
Less efficient mouth breathing.
Much less. Then air goes down the larynx, the trachea or windpipe, and then it branches, like an upside-down tree, into smaller and smaller bronchi. Figures 28.1 and 28.2 show this really well.
And defenses.
Yeah.
The body must protect this vital pathway.
Oh, absolutely.
Yeah.
Table 28.1 lays it out. You've got nasal hairs, the mucus blanket trapping stuff, tiny cilia constantly sweeping upwards.
Like little escalators.
Exactly. And irritant receptors that trigger coughs or sneezes.
Yes.
But deep down in the alveoli, you have these amazing alveolar macrophages.
The cleanup crew.
Precisely. We touched on them back in Chapter 6. They engulf debris, bacteria. Incredibly important.
So down at the end of the line, the gas exchange zone.
Right. The acinus, this includes the respiratory bronchioles, alveolar ducts, and finally the alveoli, millions of tiny air sacs.
And this is where type I and type 2 cells come in.
Yes. Type I cells form the structure, the thin walls. Type 2 cells are crucial. They secrete surfactant.
Surfactant. We'll come back to that. It sounds important.
Vitally important. And look at figure 28.3c and 28.4. They show the pores of cone.
Pores of cone.
Tiny openings connecting adjacent alveoli. Have a backup system, allowing collateral ventilation if one small airway gets blocked. Really clever design.
Wow. Okay, what about blood supply?
2 circuits. The main one for gas exchange is the pulmonary circulation. It's unique low pressure,
Right.
but handles the entire cardiac output from the right heart.
And the key interface is the alveolo-capillary membrane, figure 28.5.
Exactly. It's incredibly thin, just perfect for gases to diffuse across. If that membrane thickens, say from inflammation or fibrosis, gas exchange suffers badly.
And the other circuit.
The bronchial circulation, that's part of the systemic circulation.
Mm.
It feeds the lung tissue itself, the bronchi, but doesn't do gas exchange.
Interesting. And how is blood flow controlled in the lungs?
This is really neat. Hypoxic pulmonary vasoconstriction.
Meaning?
If an area of the lung isn't getting much oxygen, low PaO2, the blood vessels in that area constrict.
Why would it do that?
It's smart locally. It shunts blood away from the poorly ventilated bits towards areas that are getting oxygen, improves efficiency.
Potential downside.
Big downside if it happens everywhere.
Yeah.
If the whole lung has low oxygen, you get widespread vasoconstriction, leading to pulmonary hypertension, high pressure.
And that strains the right heart.
Exactly. That can lead to right heart failure, what we call cor pulmonale. Acidemia, low pH, can also trigger this constriction.
Okay, and quickly, the chest wall and pleura.
The chest wall protects everything. Muscles like the diaphragm and intercostals drive breathing movements. The pleura are 2 thin membranes.
Visceral and parietal.
Right. Visceral covers the lung, parietal lines the chest wall. Between them is the pleural space, and crucially, it has negative pressure. Figure 28.6 shows this.
Why is negative pressure important?
It acts like suction, holding the lungs open against the chest wall. If you lose that negative pressure, like in a pneumothorax, the lung collapses.
Got it. So structure down, how does this all translate into the function of breathing?
Well, first let's clarify terms. Ventilation is just the mechanical movement of air. Respiration is the actual gas exchange at the cellular level.
And minute volume.
That's just how much air you move per minute. But some of that air doesn't participate in gas exchange. That's dead space ventilation.
Now, the control systems, you mentioned it's involuntary.
Largely, yes. The respiratory center in your brainstem sets the basic rhythm. It gets input from various receptors.
Like lung receptors.
Yeah, irritant receptors trigger coughs. Stretch receptors prevent overinflation. That's the Herring-Brewer reflex. And J receptors sense fluid buildup.
And chemoreceptors.
Super important. Central ones in the brainstem monitor CO2 and pH in the cerebrospinal fluid. They're the main drivers of ventilation normally.
So if CO2 goes up,
You breathe faster and deeper to blow it off. Peripheral chemoreceptors, mostly in the carotid arteries, watch arterial oxygen, BaO2, but they only really fire up strongly if oxygen levels drop quite low.
the book has a box, changes in the chemical control of breathing.
Right, and it highlights how conditions like chronic sleep apnea or heart failure can actually blunt the sensitivity of these chemoreceptors, which is a big clinical issue.
Okay, let's talk mechanics, muscles involved.
Inspiration, breathing in, is active. The diaphragm contracts and flattens. The external intercostals pull the ribs up and out. See figure 28.9 for accessory muscles used in distress.
And expiration.
Normally passive,
Yeah.
the muscles relax, and the natural elastic recoil of the lungs pushes air out.
Elastic recoil. And you mentioned surfactant before?
Yes. Alveolar surface tension is a big force trying to collapse those tiny air sacs. Think bubbles. The law of Laplace explains this.
So smaller bubbles want to collapse more.
Exactly. Surfactant, made by those type 2 cells, dramatically reduces the surface tension. It's like a detergent, keeping the alveoli open and making them easier to inflate. Absolutely critical.
So lungs need to be stretchy, compliant.
Right. Compliance is how easily the lungs stretch. It's balanced by elasticity, the tendency to snap back or recoil. Figure 28.0 illustrates this balance. Stiff lungs have low compliance.
And airway resistance.
How much opposition air face is moving through the tubes? It depends on tube length. Radius is huge. A small change makes a big difference. And the total cross-sectional area. Bronchodilation opens airways, reducing resistance. Bronchoconstriction closes them, increasing it.
Pulmonary function tests, PFTs, measure this stuff, like in figure 28.11.
Exactly. They give us numbers for lung volumes, airflow rates reflecting compliance, resistance, and overall function.
Okay, let's bring it all together. How do the gases actually move?
It's a sequence. Oxygen comes in, diffuses into blood, binds to hemoglobin, gets transported, released to tissues. CO2 goes the other way. Produced by tissues, transported in blood, diffuses into alveoli, exhaled out.
And it's driven by pressure differences, partial pressures.
Precisely. Gases move down their pressure gradients. We can calculate the partial pressure of oxygen in the alveoli, the PaO2, it depends on barometric pressure, water vapor, the fraction of inspired oxygen, FiO2, and how well you're ventilating.
There's an example calculation in the book, and table 28.2 lists key abbreviations.
Yep, very helpful reference.
Now, this VHQ show thing again, distribution of ventilation and perfusion.
Right. It's not perfectly even throughout the lung. Gravity plays a big role. When you're upright, blood flow, perfusion, Q, is best at the bases, the bottom of the lungs.
Makes sense. Gravity pulls blood down.
And ventilation V is also generally better at the bases, though the difference isn't as stark, so the VHQ show varies. See figures 28.3 and 28.14.
But overall, the normal ratio is about 0.8.
Yeah, meaning perfusion is slightly greater than ventilation overall. Mismatches are a major cause of problems, as we'll see.
Okay, oxygen transport. It binds to hemoglobin.
Overwhelmingly.
Yeah.
About 97% hitches a ride on hemoglobin in red blood cells. Only a tiny bit dissolves in plasma.
And the oxyhemoglobin dissociation curve, figure 28.15. That looks important.
It is important.
Yeah.
It shows how readily hemoglobin hangs onto or releases oxygen depending on the partial pressure of oxygen.
And it can shift.
Yes, a shift to the right means hemoglobin releases oxygen more easily. This happens with acidosis, high CO2, increased body temperature, or more 2,3-DPG, all things that happen in active tissues.
That's the Bohr effect.
That's the Bohr effect.
Yeah.
A shift to the left means hemoglobin holds on tighter. Happens with alkalosis, low CO2, low temperature.
Clever system. What about CO2 transport?
CO2 is much more soluble than O2, about 20 times more, so it diffuses easily. It's carried in three main forms. Dissolved in plasma, as bicarbonate ions, this is the biggest chunk, and bound to hemoglobin.
And the Haldane effect.
That's the flip side of the Bohr effect. When oxygen binds to hemoglobin in the lungs, it actually makes hemoglobin release CO2 more readily, helps efficiently dump CO2 for exhalation.
Brilliant. Before we leave chapter 28, a quick word on aging.
Yeah, geriatric considerations. Basically, things get a bit stiffer and less efficient, chest wall compliance decreases, elastic recoil diminishes, the capillary network might shrink.
So maybe lower baseline PO2?
But often, yes. And the respiratory centers might become slightly less sensitive, just a gradual decline in reserve capacity.
Okay, that sets the stage perfectly. Now, chapter 29, alterations of pulmonary function in adults. This is where we see what happens when that healthy system goes wrong.
Right, and we start with the signs and symptoms that clue us in. Dyspnea is a big one, that feeling of breathlessness.
And it has different flavors, like orthopnea.
Yes, difficulty breathing lying flat. Or PND, paroxysmal nocturnal dyspnea, wake up suddenly gasping for air, often signals heart failure.
Cough is another obvious one.
Protective reflex, but chronic cough needs investigation. Could be asthma, GERD, chronic bronchitis, many causes.
What else should we look for?
Abnormal sputum, hemoptysis coughing up blood, which needs urgent attention. Abnormal breathing patterns like Kussmaul breathing, deep and rapid, seen in acidosis, or Cheyne-Stokes, cycles of deep and shallow breathing.
Cyanosis, the blue tinge.
Yes, but remember, it's often a late sign of low oxygen. Look at nail beds, lips. And clubbing, the bulbous fingertips in figure 29.1 suggest chronic hypoxemia. Chest pain can also occur, maybe from the pleura.
Okay, specific conditions. Hypercapnia.
Too much CO2, usually from hypoventilation, not breathing enough, can be caused by drugs depressing the respiratory drive, neuromuscular disease, airway obstruction,
And hypoxemia.
low oxygen in the arterial blood. The most common cause, as we discussed, is Veach-Kuch mismatch. Figure 29.3 shows this well.
Shunting versus dead space.
Exactly. Shunting is low Veach-Kuch, blood flows past unventilated alveoli, like wasted perfusion. Alveolar dead space is high Veach-Kuch air, ventilates alveoli that have no blood flow, wasted ventilation. Diffusion problems, like a thickened membrane, can also cause hypoxemia.
And if these get bad enough, acute respiratory failure.
Right, defined by specific low PO2 and/or high PO2 levels. It's a common endpoint for many lung diseases. Prevention, like deep breathing and walking after surgery, is key.
Let's look at problems with the container, chest wall, and pleura.
Chest wall restriction things hindering movement, obesity, severe scoliosis, kyphoscoliosis, muscle weakness from polio or myasthenia gravis, even severe pain.
And flail chest, figure 29.4.
That's traumatic. Multiple rib fractures let a segment move paradoxically in on inhalation, out on exhalation. Severely messes up mechanics.
Pleural problems, pneumothorax.
Air in the pleural space collapsing the lung, figure 21.5 shows it. Can be spontaneous from a ruptured bleb or secondary to trauma or lung disease like emphysema.
And tension pneumothorax is the dangerous one.
Life-threatening. Air gets in but can't get out, builds pressure, shifts the heart and vessels, needs immediate decompression.
Pleural effusion.
Fluid in the pleural space. Table 29.1 lists types. Transsudative, watery, often from heart failure. Exudative, protein-rich from inflammation infection. Empyema, pahas, hemothorax blood. Cheliothorax, lymphatic fluid.
Empyema is pus.
Usually from bacterial pneumonia spreading into the pleural space.
Okay, moving into the lung tissue itself. Restrictive versus obstructive. Let's start with restrictive difficulty expanding.
Aspiration is a big one. Fluid or solids getting into the lungs. The right lower lobe is anatomically prone, can cause nasty pneumonia, damage surfactant.
Atelectasis, lung collapse.
Yes, collapse of alveoli. Often happens post-surgery. That's why encouraging deep breathing is crucial, helps pop open those pores of Kohn, redistribute surfactant. Figure 29.6 is helpful here.
Pulmonary fibrosis.
Scarring. Excessive fibrous tissue makes the lungs stiff, non-compliant, hard to ventilate.
Inhalation disorders.
Breathing in harmful stuff. Toxic gases, too much oxygen. Oxygen toxicity, which can cause issues like BPD in infants. Dusts leading to pneumoconiosis, like coal worker's lung or asbestosis. Or allergic reactions like hypersensitivity, pneumonitis.
Pulmonary edema. Figure 29.7.
Excess water in the lung, often from left heart failure causing high pressure back into the lung capillaries, or from direct capillary injury increasing permeability like an ARDS.
And ARDS, acute respiratory distress syndrome.
A really severe form of acute lung injury. Massive inflammation, damage to the alveolo-capillary membrane, leads to leaky capillaries, fluid filling the alveoli, severe hypoxemia. Figure 29.8 shows the early exudative phase. It progresses through proliferative and fibrotic phases if recovery occurs.
Okay, now the other category, obstructive lung diseases. Difficulty getting air out.
Asthma is the classic example. Chronic inflammation, bronchial hyperresponsiveness, and reversible airway obstruction. Allergens, infections, exercise, irritants. There's a genetic link. And environmental factors play a role. The hygiene hypothesis suggests less early exposure might increase risk. The microbiome might also be involved.
Pathophysiology.
There's an early asthmatic response. Mast cells release mediators like histamine, causing bronchospasm within minutes. Figures 29.9, 29.9 show this. Then, hours later, a late asthmatic response with influx of inflammatory cells like eosinophils, causing more inflammation and potentially airway remodeling over time.
Symptoms.
Wheezing, cough, shortness of breath. A severe, unrelenting attack is status asthmaticus, a medical emergency.
Then COPD, chronic obstructive pulmonary disease.
The big umbrella term, mostly caused by smoking, covering chronic bronchitis and emphysema.
Chronic bronchitis first.
Characterized by hypersecretion of mucus and a chronic productive cough for at least 3 months of the year for 2 consecutive years.
What's happening in the airways?
Inflammation, swelling, increased mucus production from hypertrophied goblet cells. The mucus is thick, plugs airways. Smooth muscle also hypertrophies. See figures 29.1, 29.13. It all leads to obstruction, especially on expiration, causing air trapping. Figure 29.14 shows that.
And emphysema.
This is about destruction. Permanent enlargement of air spaces distal to the terminal bronchioles, destruction of alveolar walls, and loss of lung elastic recoil.
Causes.
Mostly smoking, secondary emphysema. But there's also primary emphysema due to an inherited deficiency of alpha-1 antitrypsin, a protective enzyme.
What does the lung look like?
Yet large air spaces called bullae and blebs, shown in figure 29.15. Major loss of surface area for gas exchange and that crucial elastic recoil needed for exhalation. Table 29.2 compares bronchitis and emphysema symptoms.
Okay, let's shift to infections and vascular issues.
Acute bronchitis is common, usually viral, self-limiting inflammation of the larger airways.
Pneumonia.
Infection of the lung parenchyma itself can be bacterial. Streptococcus pneumonia is a common cause of community-acquired pneumonia, CAP, or viral, like influenza, or atypical,
Hospital-acquired and ventilator-associated pneumonia.
HAP and VAP, often caused by different, sometimes more resistant bacteria. The Did You Know box on VAP highlights how endotracheal tubes provide a surface for biofilms, making treatment tough. Figure 29.16 shows how defenses can be overwhelmed.
Tuberculosis, TB.
Caused by Mycobacterium tuberculosis. Airborne transmission, highly contagious. The body tries to wall it off in granuloma, or tubercle, often with caseous necrosis inside. This leads to latent TB infection in many.
Which can reactivate.
Yes, if immunity wanes due to age, illness, immunosuppression,
Abscess formation.
a localized area of lung destruction and necrosis, often after aspiration, can form a cavity, sometimes producing foul-smelling sputum.
Pulmonary vascular diseases.
Yes.
PE, pulmonary embolism.
A blockage in the pulmonary artery, usually by a clot that traveled from a deep vein in the legs, DVT. That combo is called VTE, venous thromboembolism.
Risk factors.
Venostasis, immobility, vessel wall injury, surgery, trauma, hypercoagulability, cancer, certain medications, inherited disorders.
Defects.
Depends on the size. Can cause V-huge mismatch, infarct lung tissue, or if massive, figure 29.17, cause shock and sudden death. Classic symptoms are sudden chest pain, dyspnea, tachypnea, anxiety.
Pulmonary arterial hypertension, PAH.
Abnormally high pressure in the pulmonary arteries. Often involves endothelial dysfunction, vasoconstriction, and eventually remodeling, thickening, and fibrosis of the vessel walls. Figure 29.18 illustrates this.
Leading to?
Increased workload for the right ventricle, leading to hypertrophy and eventually failure cormonal.
And malignancies.
Laryngeal cancer, mostly in men, linked to smoking and alcohol. Hoarseness is a key early sign. Figure 29.19.
And lung cancer.
Bronchogenic carcinoma. Leading cause of cancer death worldwide, about 80% linked to smoking.
Types.
Broadly, non-small cell lung carcinoma, NSCLC, includes squamous cell adenocarcinoma, most common now, large cell, figure 29.20 shows adenocarcinoma, and small cell lung carcinoma, SCLC.
SCLC is different.
Very different. Grows rapidly, metastasizes early, often associated with producing hormones ectopically, causing paraneoplastic syndromes. Table 29.3 summarizes types. New molecular and immune therapies are improving outcomes, though.
Okay, that's a heavy tour through adult problems.
Yeah.
Now, Chapter 30, alterations in children. Here's where it gets really interesting, focusing on their unique vulnerabilities.
Absolutely. Kids aren't just small adults. Their airways are smaller, chest wall more compliant, immune system immature. Everything's still developing.
Let's start with upper airway issues in kids. Table 30.1 gives an overview.
Obstruction's a big theme. Infections, foreign bodies, sleep apnea.
Croup seems common.
Very. Usually viral laryngotracheobronchitis causes swelling below the vocal cords in the subglottic area, the narrowest part of a young child's airway. Figures 30.1, 30.2 show this.
The barking cough.
The classic seal-like barking cough, yes. And inspiratory stridor, figure 30.3, that high-pitched noise on breathing in plus retractions, figure 30.4, where the chest wall sucks in.
Different from acute epiglottitis.
Totally different and much more dangerous. Epiglottitis is rapid swelling of the epiglottis, usually bacterial. Historically high B, but other bugs now too.
Symptoms.
High fever, severe sore throat, muffled voice, drooling, and often sitting forward in that tripoding position. It's a true emergency. Never try to look in their throat.
Okay. Foreign body aspiration.
Big risk in the 1 to 4-year-old group. Small objects. Button batteries and magnets are particularly nasty. Coughing, wheezing, stridor might be signs. Needs immediate action like the Heimlich maneuver.
Obstructive sleep apnea syndrome. OSAS.
Partial or complete airway obstruction during sleep. Snoring, labored breathing, often due to large tonsils and adenoids, but obesity and craniofacial issues contribute. Can really impact daytime function, learning.
All right, moving down to the lower airways in children. Development is key here.
Definitely. Starting with newborns, especially preemies, surfactant deficiency disorder, SDD or RDS.
Respiratory distress syndrome, because they lack mature surfactant.
Exactly. Without it, their alveoli collapse, atelectasis, with each breath. Causes severe hypoxemia, increased work of breathing. Figures 30.5, 30.6 show the signs.
But treatments have improved.
Dramatically. Giving steroids to the mother before premature birth helps mature the lungs, and giving surfactant directly to the baby after birth has been revolutionary.
What about long-term consequences, BPD?
Bronchopulmonary dysplasia, or chronic lung disease of prematurity, often follows severe SDD needing long-term oxygen or ventilation. It's basically arrested lung development.
What does new BPD look like? Table 30.2, figure 30.7.
Fewer, larger, simpler alveoli, less surface area for gas exchange, maybe some fibrosis in the capillaries, lifelong implications.
Lower respiratory infections in kids. Table 30.3 lists some.
Bronchiolitis is a big one, especially in infants and toddlers, usually caused by RSV, respiratory syncytial virus.
Makes happen.
Inflammation, swelling, mucus plugging in the very small airways, bronchioles, leads to wheezing, air trapping. It's also linked to a higher risk of developing asthma later.
Pneumonia in children.
Can be viral, RSV, flu, or bacterial. Strep pneumo is still common, though vaccines help. Atypical pneumonia from mycoplasma or chlamydophila is common in school-aged kids.
Aspiration pneumonitis.
Inflammation from aspirating substances. Chronic aspiration, especially in kids with neurological problems, is sadly a major cause of morbidity and mortality.
Asthma in childhood.
Similar basic pathophysiology to adults, chronic inflammation, hyperreactivity, but triggers can be different. Viral infections are huge triggers in kids. Diagnosing in very young children can be tricky.
The book mentions exercise-induced bronchoconstriction, EIB.
Yeah, the Did You Know box highlights this. Common in kids with asthma, but can happen even without diagnosed asthma. Airways narrow during or after exercise.
ARDS in children.
Similar to adults, severe alveolo-capillary injury, inflammation. Diagnosis often uses the oxygenation index, OI, to gauge severity.
Cystic fibrosis, CF. You mentioned this earlier.
Yes, an autosomal recessive genetic disorder. A defect in the CFTR gene messes up chloride transport.
Leading to thick mucus.
Exactly. Thick, sticky, dehydrated mucus plugs, airways in the lungs, ducts in the pancreas, affects the reproductive tract. In the lungs, figures 30.8, 30.9, it leads to chronic infection, inflammation, often with biofilms, and progressive damage like bronchiectasis.
But there's progress.
Huge progress. Newborn screening, highlighted in the Did You Know box, allows early diagnosis and treatment. And new CFTR modulator therapies that target the specific genetic defect are changing lives.
Lastly, a very tough topic. SIDS.
Sudden infant death syndrome. The unexplained death of an infant under 1 year, usually during sleep.
Peak incidence.
Typically between 2 and 4 months. It's thought to involve a vulnerable infant, a critical developmental period, and an environmental stressor.
Key risk factors.
Prone sleeping position is the big one. Soft bedding, overheating, exposure to cigarette smoke.
The Back to Sleep campaign.
Had a massive impact. Educating parents about safe sleep on the back, firm mattress, no soft bedding has significantly reduced SIDs rates. Shows the power of public health initiatives.
Wow, what an incredible journey through the pulmonary system, from, the intricate dance of gas exchange and healthy lungs to the myriad ways disease can disrupt that vital process across a lifetime.
It really is incredible. Both adults and children face unique challenges.
It really highlights how interconnected everything is, doesn't it? And how much relies on these mechanisms working just right.
Indeed. And what's truly fascinating, I think, is how understanding these basic mechanisms like surface tension, negative pressure, VQ matching isn't just academic. It directly informs how we treat patients, how we prevent problems.
It gives you a real appreciation for something we normally take for granted, just breathing. As we wrap up, what's a final thought you'd leave our listeners with? Something to kind of mull over?
Well, we've talked about so many factors affecting lung health, genetics, environment, infections, lifestyle, age. It makes you wonder, thinking about preventing pulmonary disease across a whole lifetime, what single habit or intervention do you think has the most profound, far-reaching impact?
That's a powerful question to end on. A lot to consider there. Thank you for joining us for this deep dive into the pulmonary system. Last Minute Lecture Team, a warm thank you from the Last Minute Lecture Team.